Ulcer complications may be hemorrhage, obstruction, and perforation. Hemorrhage, especially, it is most common in gastric, and in duodenal, posterior hemorrhages are most common. And also, ruptured gastric ulcer is present on lesser curvature that will lead to bleeding from left gastric artery because that supplies that area. And ulcer on posterior wall of duodenum, there will be bleeding from gastroduodenal artery. Obstruction can mean pyloric channel or duodenal. Perforation, duodenal anterior perforation is greater than posterior. Here you can see this is the anterior perforation. Because of that, it is leading to anterior abdominal into the anterior abdominal cavity. That is leading to pneumoperitoneum. That is air under the diaphragm. You can see clearly in this X-ray. Free air under diaphragm. That is called as pneumoperitoneum. Because of this, there will be referred pain to shoulder via irritation of phrenic nerve. And next, coming to acute gastrointestinal bleeding, it is divided into upper GI bleeding, lower GI bleeding. Upper GI bleeding is originating proximal to ligament of Treitz, and if the bleeding is from the distal to ligament of Treitz, that is the lower GI bleeding. It is usually present with hematemesis, that is blood vomiting, but this one is distal to ligament of Treitz, that is lower GI bleeding, presents with hematochezia, that is bright red blood in stools, and it is also associated with inflammatory bowel disease, diverticulosis, angiodysplasia, hemorrhoids, anal fissure cancer, all these conditions which are affecting below the ligament of Treitz. Above the ligament of Treitz, it is associated with peptic ulcer disease, variceal hemorrhage, and also perforation of pancreatitis. Next, coming to metaplastic atrophic gastritis. In the name itself, we can understand. Metaplastic means the tissue is changing, atrophic gastritis. And this is chronic inflammation of this intestinal metaplasia that is linked to goblet cells in stomach. Hypertrophic gastropathies, enlarged rugal folds caused by hyperplasia. Dyspepsia is whenever you see any patient with dyspepsia, if their age is greater than 55, then if the alarm symptoms are present, then we need to do upper GI endoscopy. If no, then we should check for H. pylori. If H. pylori is not present, then we can give proton pump inhibitors. But if H. pylori is present, then we need to go for treatment. Now let us begin with malabsorption syndromes. In that, the first one is celiac disease. Actually, it is a type 4 hypersensitivity reaction. The problem in celiac disease is actually the gluten is not, the gluten rich foods are not good for these people, because gluten is actually made is nothing but gliadin plus glutenin. Gliadin plus glutenin together form gluten. So especially the gliadin part is allergic to these patients, because this gliadin is converted by tissue transglutaminase into deaminated gliadin. In this deaminated gliadin will along with the T cell, it will act like an antigen, and that will lead to production of antibody against this T cell. Like you can see anti-TTG, that is anti-tissue transglutaminase, anti-deaminated gliadin, anti-endomysial. So all these antibodies are formed against this. So because as antibodies are formed against this, it is like a type 4 hypersensitivity reaction. Because of this, the problem is arising, and that's why these people can't digest this kind of gluten containing foods, and their villus will also undergo atrophy. You can see here, because these antibodies are attacking on the small intestine cells, and the villus will undergo atrophy. And there is also crypt hyperplasia. You can see this diagram here, the crypts have undergone hyperplasia, they have become very large. This disease is also called as gluten sensitive enteropathy and celiac sprue, that is autoimmune T cell mediated intolerance of gliadin. It is a gluten protein found in wheat, barley, rye, associated with HLA-DQ2, HLA-DQ8, especially seen in Northern European descent people. Primarily affects the distal duodenum or proximal jejunum. There is malabsorption and steatorrhea. So what happens is there's malabsorption, and that will lead to loss of fat in the fecus, and there is also destruction of small intestine. So treatment for these people is to try gluten-free diet. They should not have gluten in their food. If in future, if this continues, that will also lead to iron deficiency, anemia, weakness, weight loss, all these problems. Always we should check for IgA antibody in these people, because it is also causing to IgA deposition in dermal papillae, causing dermatitis herpetiformis, and in future this may also increase risk of malignancy like T cell lymphoma and adenocarcinoma of small intestine. And one more thing is we need to check for IgA. If the IgA is low, then you can check next for IgG. Actually, the first thing which we need to check in this celiac sprue is this TG, that is the tissue transglutaminase. If tissue transglutaminase is present, then you can confirm it as a celiac disease. If this tissue transglutaminase is absent, even this is absent but IgA is present, then also you can say normal, it is nothing but no disease. But if tissue transglutaminase, if this is present, then you can confirm it as celiac sprue or gluten sensitive enteropathy. Next, coming to lactose intolerance. Actually, the people who drink milk, sometimes it is not good for them because it will cause diarrhea, loss of fat in their fecus, all this, because there are lactate deficiency, they're having lactase deficiency, so they can't digest milk. Actually, lactose is nothing but made up of galactose and glucose. So actually this lactase enzyme will fall with age. Older people have that does not have that much capacity to digest the lactose. So because of that, that will lead to osmotic diarrhea with decreased stool pH, and colonic bacteria can ferment lactose. So what we do is we do a lactone hydrogen breath test. As the bacteria can ferment this lactose, it will form hydrogen if there is lactose. So for lactose malabsorption, if post lactose breath hydrogen is greater than 20 compared with baseline, so if it is greater than 20, then you can say yes, there is a lactase deficiency, because if the lactose is present for longer time in the lumen, that bacteria will try to degrade it, and that will lead to increased hydrogen. Next, coming to pancreatic insufficiency. Pancreas forms many bicarbonate, and also it forms many enzymes which are required for digestion. So if that is not present, you can understand, especially in chronic pancreatitis, cystic fibrosis, cancer, all these conditions, there will be malabsorption of fat and fat soluble vitamins, so like ADEK and also vitamin B12, that will lead to steatorrhea, decreased duodenal bicarbonate, and also fecal elastase. But the D-xylose test will be normal because it is not affecting any mucosa cells of the intestine. Next, coming to tropical sprue. In tropical sprue, entire small intestine is affected and the villi are getting blunted. This disease is called tropical sprue because it is seen mostly in travelers who are going to the tropical regions. Actually, the perfect reason is not there for this disease, but it's like similar to celiac sprue because it is also affecting the small intestine, but will respond well to the antibiotics. It will affect the mucosal absorption in the duodenum and jejunum, but can sometimes also involve the ileum, and also with time. It is associated especially with megaloblastic anemia due to folate deficiency. In hematology videos, if you remember, whenever there is folate deficiency, B12 deficiency, it will cause megaloblastic anemia, right? So treatment for this tropical sprue will be tetracycline and also folate supplementation because that is deficient here. Next, let us come to Whipple disease. So how I remember this as whipping cream, because in whipping cream, if you whip it more, you'll get foam. So that here there are foamy cells, and they're pass form positive, and they're actually formed by intracellular gram positive infection by Torferimia whipplei, and it can cause can symptoms like cardiac symptoms, endocarditis, which is culture negative, arthalgias, and neurological symptoms like confusion, hyperpigmentation, and also mesenteric lymphadenopathy. It is also associated with diarrhea, steatorrhea, most common in older males. Why there is diarrhea, steatorrhea? Because as the bacteria is increasing in small intestine, it will lead to more fermentation of bacteria, more inflammation, that will lead to chronic diarrhea, vitamin deficiency, and also obstruction and altered motility. So treatment will be ceftriaxone. There will be also associated abdominal pain. Cleaner test is used to detect the abnormal sugar absorption. Stool pH if less than 6. Most sugars are causing acidic pH. Bacterial overgrowth is the golden standard, so we can do jejunal aspirate and also lactulose test. Treatment is continue with inflammatory bowel diseases. So inflammatory bowel diseases are two types, that is Crohn's disease and ulcerative colitis. So how to remember this? I remember Crohn's disease as chronic disease of inflammation of small intestine, because it is involving the whole of small intestine, and it is involving mainly transmurally, that is all layers of the intestine are involved. Any portion of GI tract may get attacked by this, especially but the terminal ileum and colon are getting affected. There are skip lesions and also there is rectal sparing. Rectum is not involved in the case of Crohn's disease. And the gross morphology will be transmural inflammation forming fistulas, cobblestone mucosa, creeping fat, bowel wall thickening, and that shows shrink sign on small bowel. You can see here this diagram is showing a shrink sign which is seen especially near the colon and the ileum. And there are also linear ulcers formations and fissure formations. So microscopic morphology is non-scissating granulomas, that is lymphoid aggregates are present. One more thing, it is having granulomatous Th1 mediated inflammation in Crohn's disease, and the complications are malabsorption and malnutrition. You can understand now the intestine has got inflamed, so that the substances of food we eat are not getting absorbed. So because of that, there is malnutrition, and there is also increased risk of colorectal cancer. Why colorectal cancer? Because it is mostly involving the ileum and colon, so colorectal cancer chances are increased. And also fistula formation, that is enterovesical. Entero means intestine, vesicle means your urinary bladder. So between the bladder and the intestine, if there is a fistula, I can understand it may cause recurrent UTI infections, because all the food contents which are in the small intestine will go into your bladder, and that will lead to very big problem, UTI. And also nematuria. Nematuria means air inside the bladder. Okay, and because small intestine have air, so that air passes here. And phlegmon or abscess may form, strictures may form, causing obstruction and perianal disease, and also abdominal pain, all these problems. So intestinal manifestation is diarrhea that may or may not be bloody. Next, extraintestinal manifestations, like on the skin you get rashes, pyoderma gangrenosum, erythema nodosum, and in eye inflammation is there, episcleritis, uveitis, ulcerations are aphthous ulcers. If you remember in our previous video, I showed the aphthous ulcer which are punched out ulcers with yellow coloration, right? And arthritis, peripheral arthritis, spondylitis, erythema nodosum, all these are present. Next, kidney stones. Kidney stones are present usually calcium oxalate, and gallstones are also may be present. May be positive for anti-saccharomyces cerevisiae antibodies. Smoking may worsen the outcome. Treatment is glucocorticoids, azathioprine, antibiotics, and biologics like infliximab, adalimumab. So whenever you see mab, ab, this at last ab, that refers the antibody. Okay, this drug itself have antibody. Next, disease activity, fecal calprotectin protectin used to monitor activity and distinguish from non-inflammatory diseases, that is irritable bowel. So let us see ulcerative colitis. It is Th2 mediated. So that is Th1. This is Th2 mediated. In the name itself, you can see ulcerative colitis means ulcers are present, and also inflammation of colon is present. Okay, so colon inflammation with continuous lesions. There are skip lesions in Crohn's disease, ulcerative colitis, continuous lesions, and also rectal involvement. In Crohn's disease, no rectal involvement, and here the mucosa, submucosa are only inflamed, but here entire layer, that is mucosa, submucosa, muscularis externa, all are inflamed. Here only mucosa, submucosa, because ulcers, if you remember, only affect the mucosa, submucosa. And there is a friable mucosa with superficial deep ulcerations. So here you can see in this diagram, these are the deep ulceration, and because of these ulcerations, there is hostra loss. Hostra are like bumpy surfaces which are present on your small intestine. So if the hostra are lost, small intestine will appear like a lead pipe, just like a pipe on imaging. And there will be left lower quadrant pain, and that will lead to pseudo polyps, and later again healing ulcers are also present. Next, crypt abscess ulcers are present. Bleeding is present here. There in Crohn's disease, no bleeding. Here bleeding is present because there is an ulcer, right? But there is no granuloma. But in Crohn's disease, there is granulomas, non-scissating granulomas. There will be PMN infiltration in ulcerative colitis. Next, fulminant colitis, toxic megacolon, that is distension and rupture wall, that will lead to perforations. Toxic megacolon is the megacolon. The colon has got lot of distension, and finally the wall is getting ruptured, and that is leading to further perforations. And also there is pyoderma gangrenosum, deep necrotic skin ulcer, ankylosing spondylitis, uveitis, adenocarcinoma, pancolitis on right side. Treatment is colectomy. All these are involved. Next, bloody diarrhea, that is very important, with nocturnal pain. And primary sclerosing cholangitis, that is associated with MPO, ANCA, and P ANCA. So if P ANCA, that's stress, polyangiitis, ulcerative colitis, all these are associated with P ANCA. Smoking may improve outcome here. This is very funny thing. Smoking already always affects in some problems, but that's why this is unique thing which we need to remember. Smoking is improving the outcome in the case of ulcerative colitis. Treatment is 5 amino salicylic acid preparations like melsalamine and also 6 mercaptopurine, infliximab, and colectomy. That is just removal of that colon which is affected by ulcerative colitis. And also we can use sulfasalazine which protect for ulcerative colitis, activate only in colon. Actually sulfasalazine is best for the ulcerative colitis because this drug travels all along the intestine but it gets activated only in the colon. So because of that it is good drug for ulcerative colitis because the problem is only in colon. But Crohn's disease, as I said, it's a, you can remember it like a chronic disease, is a effect, it can affect whole of the GI tract, but of course it also has some specific site like terminal ileum and colon. So by that we understood the inflammatory bowel diseases. Now coming to microscopic colitis. In the name itself you can see it's microscopic. We can't see this normally. We can't see this normally on endoscopy. Only when you do histology then you find that lymphocytes infiltrate are present in lamina propria with intraepithelial lymphocytosis and thickened subepithelial collagen band. So it is actually inflammatory disease of colon. It is causing chronic watery diarrhea. Even in Crohn's disease, ulcerative colitis, you see diarrhea, but in ulcerative colitis, important thing, there is diarrhea with blood. Okay, here blood may be sometimes present or not. Now let us discuss about irritable bowel syndrome. Actually, it's irritating, especially for females who are middle aged. Like that, I remember why it is irritating, because it is always related to either constipation problems or either diarrhea problems. There is no any structural deformity in this syndrome. Only there is problem related to defecation, that is change in stool frequency or change in form of stool consistency. So that's like related to somewhat stool, like either diarrhea or constipation. It is associated with fibromyalgia, some mood disorders like anxiety, depression. First line treatment is lifestyle modification and dietary changes. That's it. It's a functional disorder. Okay, it's not a structural disorder. Abdominal pain. The main symptom of this irritable bowel disease is a middle-aged female who is always having recurrent episodes of abdominal pain which are like greater than or equal to 2. So then, and that too, it is lasting for about 3 months, about 3 days per month. They are getting the abdominal pain 3 days per month, and also it is lasting for 3 months. That is irritable bowel syndrome. Now let us come to appendicitis. Appendicitis is the most common problem. You can see this in both adults and children. In adults, it is because of blockage of appendix by fecolith, that is a fecal matter which is getting stuck there, and that is causing further inflammation. Whereas in children, you can say it because of lymphoid hyperplasia. Lymphoid will get hyperplasia there, so that it will cause pain. So actually here, if the appendix will get obstructed, it will form a closed loop like structure. This yellow arrow represents appendix. Here it is forming a closed loop like structure, and because of that there will lead to increased intraluminal pressure, stimulation of visceral nerve afferent fibers like T8 to T10, that will lead to diffuse periumbilical pain, and this inflammation can extend even to cirrhosis and sometimes irritate the parietal peritoneum. So the pain is localized first to the right lower quadrant, or you can say McBurney point, that is 1/3 distance from right anterior superior iliac spine to umbilicus. So it will be in that McBurney point is special for this appendicitis. Also nausea, fever may present. If it perforates, then it may also go into peritoneum and cause peritonitis, and this will elicit psoas, obturator and rousing sign. So there will be severe right lower quadrant pain with palpation of left lower quadrant pain. So actually if you are palpating on left lower quadrant, you are getting pain on right lower quadrant, that is called rousing sign. So there will be also guarding and rebound tenderness. Why rebound tenderness, guarding? When when peritoneum is involved, these symptoms are present. So there is acute abdomen perforation, peritonitis, rigid abdomen. Treatment is appendectomy. Next, coming to diverticula of GI tract. So GI tract have diverticulum. What is diverticulum? What is diverticulosis? What is diverticulitis? Let us differentiate between these three diseases. Actually, you can see here this is a diverticulum. It's a normal outpouching which is in connection with the lumen. So you can say the esophagus, stomach, duodenum, all these are diverticula. All these are diverticulum because they are still in connection with the lumen. They are always a false diverticulum because they contain only mucosa and submucosa. Whereas some diverticulum are called true diverticulum, like Meckel diverticulum, because it contains all gut wall layers. Next, coming to diverticulosis. Diverticulosis is nothing but outpoaching of some false diverticula from the colon especially, and that too it is seen mainly in the sigmoid colon. Why? Because someone are having constipation, so they're putting more pressure. So because of that, their colon is getting outpoached outside, and that is called diverticulosis because of increase in intraluminal pressure. This is associated with obesity and low fiber diet and eating high total fat and eating more red meat. So these patients are often asymptomatic. Sometimes they may have discomfort. So complications are like diverticular bleeding. There will be painless hematochezia, that is bright red blood coming from your fecal matter along with your fecal matter, but it is painless. And next, coming to diverticulitis. Diverticulitis is inflammation of one specific diverticulum, and this is classically causing left lower quadrant pain. Sometimes fever is present, leukocytosis because of inflammation. You can treat it if with supportive care if it is uncomplicated, but if it's complicated because of some organisms like microorganisms, then you need to give antibiotics. Sometimes diverticulitis is called left side appendicitis. Why left side appendicitis? Because appendicitis is normally on right side in McBurney point you get the pain, but in diverticulitis you get pain on the left side, and there is also occult blood in stool, and sometimes they may form fistula like colovesical fistula that will lead to hematuria and obstruction, and also it may cause perforation. You can see here this white arrows, this is perforation that will lead to peritonitis, and hematochezia is rare, that is blood vomiting is rare. Now let us understand Zenker diverticulum. Zenker diverticulum is a problem. Actually, it is a defect in the thyropharyngeus muscle and cricopharyngeal muscle. Actually, it's not a defect. It is a weakness between these muscles, that is forming a Killian triangle here. Actually, this Killian triangle is present in the hypopharynx. So from this, the Zenker diverticulum is coming out. You can see this is nothing but the mucosa of the esophagus which is coming out. So because of this weakness here, there is a problem in swallowing, that there is dysphagia, there is obstruction, and there is also gurgling problem, and there is aspiration and also foul smell because the food is getting accumulated here in the Zenker diverticulum. This will also lead to neck mass, and it is most commonly seen in older males, and there is also halitosis, that is food is trapped in the diverticulum. So there is a cricopharyngeal muscle fail to relax. So because of that there will be difficulty in swallowing. You can see this in the x-ray like this, Zenker diverticulum. This is the diverticulum coming from the esophagus, and it's a false diverticulum because it contains only mucosa. Now coming to Meckel's diverticulum. Actually, Meckel's diverticulum is, that there will be a physiological outpouching in the 6th week, but that outpouching is failed to go inside again, and that is leading to Meckel's diverticulum. It's actually a true diverticulum, and this is the most common congenital anomaly of GI tract, which we see among everything. The most common congenital anomaly is Meckel's diverticulum. It is called true diverticulum because it have all the layers like mucosa, submucosa, muscularis externa, all the layers are present. It is nothing but it's a persistence of vitelline omphallomesenteric duct. So sometimes because it is related to the GI system, it may also have ectopic acid secreting gastric mucosa, or sometimes even pancreatic tissue may be present here, and this will lead to right lower quadrant pain, sometimes intersusception, volvulus, and also obstruction near terminal ileal. And the diagnosis is technetium per technate snacks, and this is also called Meckel scan for uptake by heterotropic gastric mucosa. So there's a rule of 2 for Meckel's diverticulum, that is 2 times likely in males, 2 inches long, 2 feet from ileocecal valve, and it is present only in 2% of population, and it will commonly present in first 2 years of life. So everything is related to 2. So that's why it is called rule of 2, and it may have 2 types of epithelia, that is either gastric epithelia or pancreatic, as we discussed before. So this is Meckel's diverticulum. Next we'll discuss about Hirschsprung's disease. In this disease, the problem is loss of Orbach and Meissner's plexus, that is the ganglionic cells are absent. So because of this, you can understand there will be no normal peristalsis, and the fecus cannot get out. So due to failure, actually this is due to failure of neural crest cell migration. It is associated with loss of function mutation of RET. How to remember that RET? RET mutation in rectum. Okay, like that you can remember. It is present with bilious emesis because already it has crossed the biliary duct, right? It is also present with abdominal abdominal distension, failure to pass meconium within 48 hours. There's chronic constipation, and the normal portion of colon proximal to ganglionic septum is dilated, that is causing a transition zone. And in barium imaging, if you see, the proximal bowel will be normal, but the distal bowel will be small. So you can see proximal bowel is normal, it is distended, and bowel the distal bowel, you can see it's abnormal, it is distended. Sorry, proximal bowel will be normal, but the distal bowel will be, you can see, distended like this. That is because of loss of ganglionic cell, and it is having increased risk with Down syndrome. And sometimes there will be explosion of fecus, and that is called squid sign, empty rectum on digital examination, and diagnosed by absence of ganglion cell on rectal suction biopsy. Actually in rectum there will be no fecus because all the fecum is stuck here, okay. And you should do suction biopsy to find out the absence of ganglion cell. And acyl cholinesterase is increase in hypertrophy nerve fibers in lamina propria. Treatment is just resection of the colon without ganglia. So if you have any colon without ganglia, just remove it because it is of no use. It will in turn obstruct the fecus. Now coming to adhesion. Adhesions are a branch of scar tissue in peritoneal cavity. They're like scar tissues in the peritoneal cavity formed after surgeries. So it is the most common cause of small bowel obstruction. Okay. And they cause bowel obstruction, infertility in females, chronic abdominal pelvic pain. Treatment is with lysis of adhesions. Bowel obstruction more common in small intestine, and abdominal pain, nausea, distension, obstipation. Small bowel obstruction is common cause for ABC, that is adhesions, bulges, hernias, cancers. Large bowel obstruction is common cause for tumors, adhesion, volvulus. So this is very important. In large bowel you'll see tumors, adhesions, volvulus. In small bowel adhesions are most common. Next, bulges, hernias are common, and cancer is common. Air, fluid, and dilated bowel loops in bowel obstruction X-ray. So if you do X-ray for this, you will see air, fluid, and dilated bowel loops. So next is small rotation. You can see here how the small intestine is on the right side. It is clumped up on the right side, and colon, you can see how abnormal it is. This is because of formation malrotation, and you can see there's formation of flat bands between the colon and liver, right? So this is all abnormality because of anomaly of midgut rotation during fetal development, and that is leading to improper positioning of bowel. Okay, the same thing you can see in the X-ray. This is small bowel, this is stomach. Next, and one more thing, this malrotation may further lead to volvulus and also duodenal obstruction. Next is intersusception. Actually it is telescoping of one segment of the GI tract into other. It is seen mainly in the ileocecal junction. For example, this is the ileum, this is the cecum. You can see how the ileum is going inside the cecum. This is called intersusception. Actually there should be some lead point which is leading to this. So the lead points in the children will be Meckel diverticulum, that is small wall hematoma, IgA vasculitis. In adults it will be intraluminal mass or tumor. This is leading to this kind of intersusception, and this is causing small bowel obstruction. Also vascular compromise, that is intermittent abdominal pain, vomiting, bloody current jelly stools. This is characteristic feature. When you see in your question current jelly stool, then you can think of intersusception. Physical exam is sausage shaped mass in right abdomen. Patient may draw their legs to the chest to ease pain because of that pain. Imaging ultrasound CT show target sign. You can see the target sign in the center. It's a medical emergency. Sometimes even infections can cause this, like adenovirus, rotavirus vaccine may cause Peyer's patch hypertrophy, and that Peyer's patch hypertrophy may act as lead point. Okay. Now let us check out volvulus. So volvulus is actually twisting of a bowel around its own mesentery. So because of this twisting, it is causing obstruction and also infarction. This will occur anywhere throughout the GI tract. And gastric volvulus is more common with anatomical abnormalities, like whenever there's paraesophageal hernia, it may cause this problem, and it will present with severe abdominal pain because of this twisting of the bowel. And there's also pain, dry heaving, and inability to pass the nasogastric tube. So midgut volvulus is more common in infants and minors. How to remember this? Midgut, minors. Secondary to Meckel's diverticulum. Sigmoid volvulus is coffee bean shape. This is actually the sigmoid volvulus. It is seen on X-ray. You can see sigmoid volvulus, coffee bean. More common in seniors. So sigmoid seniors. Okay, and more common at sigmoid colon or cecum. And there's dilated sigmoid plus airless rectum. So you can see how the sigmoid colon is twisting around its own mesentery. This is volvulus. Now let us continue with other intestinal disorders like we are having acute mesenteric ischemia. Actually, it is a blockage of intestinal blood flow. In the name itself, you can see mesenteric ischemia, loss of blood to the intestine. Okay, and it is mainly because of emboli in the superior mesenteric artery, and because of that, there is small intestine necrosis. You can see this. Structure here, this is brown color because of necrosis, low blood supply, so there will be abdominal pain out of proportion, and it may see red currant jelly stools because of low blood supply. Next, coming to angiodysplasia, actually you can see these are the tortuous dilation of vessels. This is leading to hematocesia, that is a blood in a fecus. Okay, it is most common found in right side colon. Okay, here right side colon, and more common in older patients, and it is confirmed by angiography. It is associated with sometimes end stage renal disease, von Willebrand disease, aortic stenosis. Okay, mainly seen in angiodysplasia, mainly seen in cecum and right side colon, very important. Okay, cecum and right side colon will be this side. Okay, this is left side. Next, coming to chronic mesenteric ischemia. Actually, it is also called as intestinal angina. You can see here, it is intestinal angina. There is atherosclerosis of either celiac artery or superior mesenteric artery. Most commonly, superior mesenteric artery is affected, and or inferior mesenteric artery is also affected. That will lead to intestinal hypoperfusion. So same thing as acute mesenteric, but in acute mesenteric there is emboli. Here there is atherosclerosis. That's why it is called intestinal angina. Okay, there is postprandial epigastric pain, food diversion, and weight loss. Okay, next coming to colonic ischemia. It is crampy abdominal pain by hematocesia, that is blood in a fecus. Commonly occurs at watershed areas, you know, the double supply areas like splenic flexure, rectosigmoid junction. Already I showed this before videos. So typically it affects older adults. There is thumbprint sign on imaging, and due to mucosal edema and hemorrhage. Very important is thumbprint sign. Okay, colonic ischemia in the colon, thumbprint sign. Mucosal edema and hemorrhage is also associated with this. Okay, next coming to ileus. Ileus is most commonly due to some use of narcotics, and after operation, actually it is intestinal hypomotility. Intestine should have normal motility, but the motility is lost, but there is no obstruction. Okay, that will lead to constipation, of course, because the fecus is not getting out, and decreased flatus, distended tympanic abdomen with decreased bowel sounds, associated with abdominal surgeries, opiates, hypokalemia. No transition zone on imaging. Treatment is bowel rest and electrolyte correction. Okay, electrolyte correction. If you remember the transition zone, you can see this in a Hirschsprung's disease. Okay, but not in ileus. Here the treatment is bowel rest, electrolyte correction, cholinergic drugs stimulate the intestinal motility. Don't confuse with Hirschsprung's and ileus. In Hirschsprung's disease, only the last part of the colon is affected. There is loss of ganglion cell. Here this is intestinal hypomotility, so because of that you are not getting fecus out. Okay, next, necrotizing enterocolitis. In the name itself you can see necrotizing means again there is loss of blood flow. Enterocolitis treatment is bowel rest, antibacterial, especially seen in first month of life, seen in premature formula fed infants. Still they are not eating anything. Okay, with immune immature system, necrosis of intestine mucosa, mostly terminal ileum and proximal colon, which can lead to nematosis into intestinalis, that is air into the intestinalis. Okay, you can see here nematosis, intestinalis, and also you can see pneumoperitoneum, into the peritoneum air, portal venous gas. Risk factor is enteral bleeding and bacteria. Next, coming to small bowel obstruction. Normal flow of intraluminal contents is interrupted. In the name itself you can say small bowel obstructed. As the small bowel is obstructed, fluid is getting accumulated, and intestinal dilation. Intestinal dilation, actually it will become proximal to blockage, and intestinal decompression distal to blockage. Presence with abrupt onset pain, nausea, vomiting, distension because food is not getting out, compromised blood flow due to excessive dilation, strangulation, leading to ischemia, necrosis, perforation. Most commonly caused by intraperitoneal adhesion, that is a fibrous band of tissue, tumors, hernias, and meconium ileus is actually meconium plug in newborns, and upright abdominal x-ray shows air-filled levels. Management is gastrointestinal decompression, volume resuscitation, bowel rest. Actually, we want to remove all the fecus which is stuck in the small intestine. Next, Orgleave syndrome. It is a pseudo obstruction of intestine. There's dilated colon without lesion. Actually, no problem, but why colon is dilated? Okay, it is associated with hospitalized patient uses of narcotics. Hospitalized patients, they're having less mobility, so their uh, fecus may get stuck without any problem, and if they are using any narcotics, that will also causes Orgleave syndrome. Next, hereditary hemorrhagic telangiectasia. It is also called Osler-Weber-Rendu syndrome. Okay, it is an autosomal dominant conditions. Telangiectasia mainly seen in GI tract. Nasopharynx is till rectum, up to from the nasopharynx to the rectum. You can see this is really leading to AVM, that is arteriovenous malformation. Clinical features are nose bleeding, GI bleeding, iron deficiency. Very important. Okay.